Question 1. A 7-year-old child presents with a sudden onset of difficulty breathing, stridor, and hoarseness. They are alert but anxious, and the respiratory rate is elevated. Their skin color is normal, and capillary refill is less than 2 seconds. Which of the following is the most appropriate initial action? A. Administer albuterol via nebulizer. B. Prepare for intubation. C. Provide humidified oxygen and keep the child calm in a position of comfort. D. Initiate immediate chest compressions. Answer: C. Provide humidified oxygen and keep the child calm in a position of comfort. This scenario describes a child in respiratory distress, likely due to an upper airway obstruction like croup or epiglottitis, although the child's alertness points more toward croup given the stridor and hoarseness. The concept tested is the initial management of a child with respiratory distress who still has adequate perfusion. The keywords sudden onset, stridor, and hoarseness point to an upper airway issue, while alert but anxious and normal skin color suggest they are not yet in respiratory failure. The most appropriate initial step for a child with upper airway obstruction who is still stable is to provide humidified oxygen and maintain a calm environment in a comfortable position, as agitation can worsen airway compromise. For instance, allowing a child with croup to sit on a parent's lap and breathe cool mist can significantly reduce their distress. Remember, keeping a child calm and ensuring oxygenation are paramount in early respiratory distress. Question 2. A 3-month-old infant is found unresponsive, apneic, and pulseless. A lone rescuer is present. What is the correct compression-to-ventilation ratio for this infant? A. 30:2. B. 15:2. C. 5:1. D. Continuous compressions with 1 breath every 6 seconds. Answer: A. 32. This question tests your knowledge of single rescuer basic life support, BLS, for infants in cardiac arrest. The keyword lone rescuer is crucial here, as it dictates the compression-to-ventilation ratio. For a single rescuer performing CPR on an infant or child, the recommended compression-to-ventilation ratio is 30 compressions followed by 2 breaths. This ratio helps ensure adequate circulation while also providing necessary ventilation. For example, if you were the only person present when a baby collapsed, you would perform 30 chest compressions, then give 2 rescue breaths, and repeat this cycle. Always remember that when you're by yourself, the 30:2 ratio applies to all ages in cardiac arrest. Question 3. During cardiac arrest resuscitation, what is the recommended initial dose of epinephrine for a pediatric patient? A. 0.01 mg/kg/IO. B. 0.1 mg/kg/IO. C. 1 mg/kg/IO. D. 0.01 mg/kg/IO. Answer: A. 0.01 mg/kg/IO. This question focuses on the crucial medication dosage for pediatric cardiac arrest. The concept being tested is the correct initial dose of epinephrine, a vital drug in PALS protocols. The keyword initial dose emphasizes that this is the first amount to administer. The recommended initial dose of epinephrine for pediatric cardiac arrest is 0.01 mg/kg administered intravenously, or intraosseously, IO, which is equivalent to 0.1 ml/kg of the 1:10,000 concentration. This precise dosing ensures appropriate cardiac stimulation and peripheral vasoconstriction to improve perfusion to vital organs. For instance, a 10 kg child would receive 0.1 mg of epinephrine. Always double-check your calculations and ensure you're using the correct concentration of epinephrine, 1:10,000 for 4/IO. Question 4. A 5-year-old child presents with signs of compensated shock, tachycardia, normal blood pressure, cool extremities, and prolonged capillary refill. What is the most appropriate initial fluid bolus for this child? A. 5 milliliters per kilogram isotonic crystalloid. B. 10 milliliters per kilogram isotonic crystalloid. C. 20 milliliters per kilogram isotonic crystalloid. D. 20 milliliters per kilogram hypertonic saline. Answer: C. 20 milliliters per kilogram isotonic crystalloid. This question tests the management of compensated shock in a pediatric patient, specifically fluid resuscitation. The keywords compensated shock, tachycardia, normal blood pressure, and prolonged capillary refill describe a child who is trying to maintain vital organ perfusion despite reduced cardiac output. The most appropriate initial fluid bolus for a child in any type of shock, except possibly cardiogenicity, is 20 milliliters per kilogram of isotonic crystalloid, such as normal saline or lactated Ringer's solution, administered over 5 to 20 minutes. For example, a 20 kilograms child would receive a 400 milliliters fluid bolus. Remember, prompt and adequate fluid resuscitation is critical to reverse shock and improve tissue perfusion. Question 5. Which of the following rhythm is not shockable in the pediatric cardiac arrest algorithm? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private. Answer: C. Asystole. This question focuses on the critical distinction between shockable and non-shockable rhythms in pediatric cardiac arrest. The concept being tested is the appropriate use of defibrillation within the PALS cardiac arrest algorithm. The keyword not shockable directs you to identify the rhythm that does not respond to electrical therapy. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are shockable rhythms, meaning a defibrillating shock can potentially reset the heart's electrical activity. Asystole, however, represents a complete absence of electrical activity and does not respond to defibrillation. It requires epinephrine and high-quality CPR. For instance, if a monitor shows a flat line, asystole, you would focus on CPR and epinephrine, not defibrillation. Always remember to quickly analyze the rhythm to determine if defibrillation is warranted. Question 6. A 10-month-old infant presents with a history of poor feeding, lethargy, and a weak cry. On assessment, the infant is pale, has a respiratory rate of 50 breaths/min, heart rate of 180 beats/min, blood pressure 70/40 mm of mercury, and capillary refill of 4 seconds. What type of shock is most likely present? A. Anaphylactic shock. B. Obstructive shock. C. Hypovolemic shock. D. Distributive shock. Answer: C. Hypovolemic shock. This question describes the classic signs and symptoms of hypovolemic shock in an infant. The concept being tested is the ability to identify different types of shock based on clinical presentation. Key findings like poor feeding, lethargy, weak cry, pale, tachycardia, 180 bpm, hypotension, 70/40 mmHg, and prolonged capillary refill, for seconds. All point to decreased circulating blood volume. Hypovolemic shock is characterized by a significant reduction in intravascular fluid, which can result from dehydration, hemorrhage, or severe fluid loss, leading to inadequate tissue perfusion. For example, a child with severe gastroenteritis and significant fluid loss would likely develop hypovolemic shock. Recognizing these signs quickly allows for prompt fluid resuscitation, which is the cornerstone of treatment. Question 7. What is the primary method for confirming endotracheal tube (ETT) placement in a pediatric patient after intubation? A. Auscultation of bilateral breath sounds and epigastric sounds. B. Observing chest rise and fall. C. Continuous quantitative waveform capnography. D. Chest X-ray. Answer: C. Continuous quantitative waveform capnography. This question assesses your knowledge of the most reliable method for verifying correct endotracheal tube (ETT) placement in pediatric patients. The concept tested is the immediate and ongoing confirmation of airway patency after intubation. The keyword primary method highlights the gold standard. While auscultation, observation of chest rise, and a chest X-ray are important supplementary tools, continuous quantitative waveform capnography provides real-time, objective confirmation of carbon dioxide, CO2, in the exhaled breath, indicating lung ventilation. If the ETT is in the esophagus, there will be no CO2 detected. For instance, seeing consistent square waves on the capnography monitor confirms the tube is in the trachea, whereas a flat line means it's likely misplaced. Always rely on capnography for definitive and continuous ETT placement confirmation. Question 8. A 2-year-old child presents with a barking cough, inspiratory stridor, and mild retractions. They are afebrile and otherwise appear well. Which condition is most likely causing these symptoms? A. Bacterial tracheitis. B. Epiglottitis. C. Croup, laryngotracheobronchitis. D. Anaphylaxis. Answer: C. Croup, laryngotracheobronchitis. This question describes the classic presentation of croup, a common pediatric respiratory illness. The concept being tested is the ability to differentiate common causes of upper airway obstruction in children. The keywords barking cough, inspiratory stridor, mild retractions, and being afebrile strongly point to croup, laryngotracheobronchitis. Croup is typically viral, causes inflammation of the upper airway, and often presents with these distinct symptoms, usually without a high fever. For example, a child waking up at night with a harsh, seal-like cough is a hallmark sign of croup. Recognizing these specific symptoms helps guide appropriate, often conservative, management. Question 9. What is the most common cause of cardiac arrest in infants and children? A. Primary cardiac event. B. Sudden infant death syndrome, SIDS. C. Progressive respiratory failure or shock. D. Traumatic injury. Answer: C. Progressive respiratory failure or shock. This question tests a fundamental understanding of the etiology of pediatric cardiac arrest. The concept being assessed is the typical progression leading to cardiac arrest in children. The keyword most common cause highlights the overarching reason. Unlike adults, where primary cardiac events like myocardial infarction are common, infants and children usually experience cardiac arrest as a secondary event, most often due to progressive respiratory failure or uncompensated shock. This means their heart often stops because they can no longer effectively breathe or circulate blood. For instance, a child with severe asthma attack that progresses to respiratory failure, or a child with severe dehydration leading to hypovolemic shock, might eventually experience cardiac arrest. Focusing on preventing and treating respiratory failure and shock is key to preventing pediatric cardiac arrest. Question 10. You are resuscitating a child in cardiac arrest. After administering the first dose of epinephrine, you should continue chest compressions and ventilations. When should the next dose of epinephrine be considered? A. Every 1 minute. B. Every 3 to 5 minutes. C. Only after defibrillation. D. Only after return of spontaneous circulation, RO-SCI. Answer, B. Every 3 to 5 minutes. This question tests the timing of medication administration during pediatric cardiac arrest. The concept being tested is the correct interval for repeat doses of epinephrine according to PALS guidelines. The keywords next dose and epinephrine prompt you to recall the appropriate timing for this critical medication. Following the initial dose, epinephrine should be administered every 3 to 5 minutes during ongoing cardiac arrest resuscitation. This regular dosing helps maintain its beneficial effects on cardiac contractility and systemic vascular resistance. For example, if you gave the first dose at 10:00 a.m., the next dose would be due between 10:03 a.m. and 10:05 a.m. Always ensure timely redosing of epinephrine to optimize resuscitation efforts. Question 11. What is the recommended depth of chest compressions for an infant during CPR? A. At least 1/3 the depth of the chest, approximately 1 inch, 5 cm. B. At least 1/3 the depth of the chest, approximately 5 inches, 4 cm. C. At least 1/3 the depth of the chest, approximately 2 inches, 5 cm. D. At least 2 inches, 5 cm. Answer, B. At least 1/3 the depth of the chest, approximately 5 inches, 4 cm. This question tests your knowledge of high-quality CPR techniques for infants. The concept being tested is the correct depth of chest compressions, which is vital for effective circulation. For an infant, chest compressions should be performed to a depth of at least 1/3 the anterior-posterior diameter of the chest, which is approximately 5 inches or 4 centimeters. This depth is necessary to adequately compress the heart and generate blood flow. For example, when performing CPR on an infant, you should press firmly enough to achieve this specific depth, ensuring effective blood circulation without causing injury. Remember, proper compression depth is just as important as rate and recoil for good CPR outcomes. Question 12. A 6-year-old child is found unconscious. You determine they are not breathing and have a weak, slow pulse of 40 bpm. What is your immediate next action? A. Begin chest compressions. B. Provide rescue breaths at 1 breath every 3 to 5 seconds. C. Administer epinephrine. D. Prepare for defibrillation. Answer. A. Begin chest compressions. This question presents a scenario of a child with symptomatic bradycardia that is causing clinical deterioration, bordering on cardiac arrest. The concept being tested is the recognition of bradycardia severe enough to warrant immediate chest compressions. The key findings are unconscious, not breathing, and a weak, slow pulse of 40 bpm. A child with a pulse rate less than 60 bpm and signs of poor perfusion, like being unconscious and not breathing, should immediately receive chest compressions. This is because such a slow heart rate is inadequate to maintain vital organ perfusion. For example, if you encounter a child who is unresponsive and has a very slow, ineffective pulse, starting compressions is more urgent than just rescue breaths or medications. Remember, if bradycardia causes signs of shock or impending cardiac arrest, initiate CPR. Question 13. Which of the following is the most reliable sign of impending respiratory failure in a pediatric patient? A. Increased respiratory rate. B. Mild retractions. C. Bradypnea or absent breath sounds. D. agitation and anxiety. Answer C. Bradypnea or absent breath sounds. This question focuses on identifying critical signs of worsening respiratory status in children. The concept being tested is the distinction between respiratory distress and the more severe, life-threatening condition of respiratory failure. The keyword most reliable sign of impending respiratory failure points to a direct indicator of profound respiratory compromise. While increased respiratory rate, mild retractions, and agitation are signs of respiratory distress, bradypnea, abnormally slow breathing, or absent breath sounds indicate severe fatigue or complete airway obstruction, signifying that the child's respiratory effort is failing. For instance, a child who was tachypneic but is now breathing very slowly and shallowly is likely transitioning into respiratory failure. Always recognize that a sudden decrease in respiratory effort after a period of increased work of breathing is an ominous sign. Question 14. What is the recommended initial energy dose for defibrillation of a pediatric patient in joules/kg for ventricular fibrillation, VF, or pulseless ventricular tachycardia, private? A. 0, 5J/kg. B. 1J/kg. C. 2J/kg. D. 4J/kg. Answer C. 2J/kg. This question addresses the critical aspect of defibrillation dosing in pediatric cardiac arrest. The concept tested is the correct initial energy level for electrical therapy in children. The keywords initial energy dose and defibrillation for VF/private direct you to recall the specific recommendation for the first shock. The recommended initial energy dose for defibrillation in pediatric patients is 2 joules per kilogram, J/kg. This dose aims to effectively depolarize the heart and terminate the malignant arrhythmia. For example, a 15 kg child would receive an initial shock of 30 joules. Always ensure the correct joule setting is selected on the defibrillator to maximize the chances of successful rhythm conversion. Question 15. A child presents with a rapid, weak pulse, prolonged capillary refill, and mottling. Their blood pressure is low for their age. These findings are most consistent with which stage of shock? A. Compensated shock. B. Decompensated shock. C. Irreversible shock. D. Anaphylactic shock. Answer B. Decompensated shock. This question assesses your ability to recognize the signs of a deteriorating shock state in a child. The concept being tested is the progression of shock, specifically identifying decompensated shock. The keywords rapid, weak pulse, prolonged capillary refill, mottling, and blood pressure is low for their age all indicate that the child's compensatory mechanisms are failing. In decompensated shock, the body can no longer maintain adequate blood pressure and organ perfusion, leading to overt signs of circulatory failure. For example, a child who initially had normal blood pressure with a fast heart rate, compensated shock, but now has a low blood pressure and cool, mottled skin has entered decompensated shock. Recognizing these signs is critical for prompt and aggressive intervention to prevent cardiac arrest. Question 16. What is the recommended chest compression rate for pediatric CPR? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer C. 100 to 120 compressions per minute. This question tests a fundamental component of high-quality CPR, the compression rate. The concept being tested is the correct speed for chest compressions in pediatric patients. The keyword recommended chest compression rate is central to this. For pediatric CPR, the guideline recommended compression rate is 100 to 120 compressions per minute. This rate is critical to ensure adequate blood flow to vital organs during cardiac arrest. For example, imagine pressing down on the chest to the beat of a song like "Stayin' Alive" to maintain the correct rhythm. Consistently maintaining this rate is just as important as proper depth and full chest recoil for effective CPR. Question 17. Which of the following is an immediate priority when managing a child with a severe allergic reaction, anaphylaxis? A. Administering antihistamines. B. Establishing access for fluid bolus. C. Administering epinephrine intramuscularly. D. Obtaining a detailed allergy history. Answer: C. Administering epinephrine intramuscularly. This question highlights the most critical immediate intervention for a life-threatening allergic reaction in children. The concept being tested is the initial emergency management of anaphylaxis. The keyword immediate priority emphasizes the urgency of the situation. In anaphylaxis, the most immediate and life-saving intervention is the administration of epinephrine intramuscularly, IM. Epinephrine helps reverse bronchospasm, vasodilation, and other systemic effects of the allergic reaction. For instance, if a child suddenly develops hives, wheezing, and swelling after eating a known allergen, IM epinephrine should be given without delay. Remember, prompt epinephrine administration is the cornerstone of anaphylaxis treatment. Question 18. A 4-year-old child is intubated and being mechanically ventilated during cardiac arrest. What is the recommended ventilation rate? A. 1 breath every 2 to 3 seconds, 20-30 breaths/min. B. 1 breath every 3 to 5 seconds, 12-20 breaths/min. C. 1 breath every 6 seconds, 10 breaths/min. D. 1 breath every 10 seconds, 6 breaths/min. Answer: C. 1 breath every 6 seconds, 10 breaths/min. This question specifically addresses ventilation rates during cardiac arrest once an advanced airway is in place. The concept tested is appropriate ventilation for an intubated child undergoing CPR. The keywords intubated and cardiac arrest indicate that continuous chest compressions are being performed. Once an advanced airway, like an ETT, is secured, ventilations can be provided continuously without pausing chest compressions, at a rate of 1 breath every 6 seconds, or about 10 breaths per minute. This rate avoids hyperventilation, which can be detrimental by increasing intrathoracic pressure and decreasing venous return. For example, after an ETT is placed, you would deliver a breath every time the clock hand sweeps 6 seconds, while another rescuer continues compressions without interruption. Always remember that once an advanced airway is in place during CPR, ventilation and compressions become asynchronous. Question 19. What is the primary purpose of the Pediatric Assessment Triangle, PAT? A. To perform a comprehensive physical examination. B. To quickly form a general impression of a child's physiological status. C. To determine the specific diagnosis of an illness or injury. D. To assess neurological function in detail. Answer: B. To quickly form a general impression of a child's physiological status. This question focuses on a foundational assessment tool in PALS. The concept being tested is the purpose and utility of the Pediatric Assessment Triangle, PAT. The keyword primary purpose directs you to the main goal of this quick, visual assessment. The PAT allows a healthcare provider to rapidly form a general impression of a child's physiological status by assessing their appearance, work of breathing, and circulation to the skin without even touching the child. It helps determine how sick the child is and the urgency of their condition, but not a specific diagnosis. For instance, a child who is lethargic, breathing rapidly, and mottled would immediately signal significant illness even before any vital signs are taken. Remember, the PAT is an initial across-the-room assessment, not a diagnostic tool. Question 20. A 9-year-old child has a pulse but is unresponsive and not breathing. After opening the airway and confirming no breathing, what is the next step for a single rescuer? A. Begin chest compressions. B. Give one rescue breath every 2 to 3 seconds. C. Give one rescue breath every 3 to 5 seconds. D. Call for help immediately before any intervention. Answer: C. Give one rescue breath every 3 to 5 seconds. This question presents a scenario of respiratory arrest with a pulse, which requires rescue breathing. The concept being tested is the correct rate of rescue breaths for a child with a pulse but who is not breathing. The keywords pulse but unresponsive and not breathing identify the critical need for ventilatory support. For a child, age 1 year to puberty, who has a pulse but is not breathing, rescue breaths should be administered at a rate of 1 breath every 3 to 5 seconds, which translates to about 12 to 20 breaths per minute. This rate ensures adequate oxygenation without causing hyperventilation. For example, after opening the airway, you would give a breath, count 1001, 1002, then give another breath. Remember, effective rescue breathing is critical to prevent cardiac arrest in this situation. Question 21. What is the recommended dose of intravenous, adenosine for a pediatric patient experiencing supraventricular tachycardia, SVT? A. First dose 0.1 mg/kg, second dose 0.2 mg/kg. B. First dose 0.2 mg/kg, second dose 0.4 mg/kg. C. First dose 0.5 mg/kg, second dose 1 mg per kilogram. D. First dose 1 mg per kilogram, second dose 2 mg per kilogram. Answer: A. First dose 0.1 mg/kg, second dose 0.2 mg/kg. This question tests knowledge of medication dosing for a specific pediatric arrhythmia. The concept being tested is the correct initial and subsequent dosing of adenosine for supraventricular tachycardia, SVT. The keyword adenosine and SVT are crucial. For a pediatric patient with SVT, the recommended initial 4 dose of adenosine is 0.1 mg/kg given as a rapid 4 push. If the first dose is ineffective, a second dose of 0.2 mg/kg can be given. For example, a 10 kg child would first receive 1 mg of adenosine, and if needed, then 2 mg. Always remember to administer adenosine rapidly, followed by a flush, due to its very short half-life. Question 22. Which of the following rhythms is characterized by a rapid, regular narrow complex tachycardia, with P waves often hidden or absent, and is commonly seen in pediatric patients? A. Ventricular tachycardia. B. Sinus tachycardia. C. Supraventricular tachycardia, SVT. D. Atrial fibrillation. Answer: C. Supraventricular tachycardia, SVT. This question describes the classic electrocardiographic, ECG, characteristics of supraventricular tachycardia, SVT, in children. The concept being tested is the ability to identify a common pediatric arrhythmia based on its ECG features. The keywords rapid, regular narrow complex tachycardia with P waves often hidden or absent are hallmarks of SVT. Unlike sinus tachycardia, which gradually increases and decreases and has visible P waves, SVT has an abrupt onset and offset and typically very high, sustained heart rates in children, making P waves difficult to discern. For example, if a child suddenly has a heart rate of 220 bpm with a narrow, regular QRS complex and no clear P waves, SVT should be strongly suspected. Recognizing these ECG features is crucial for guiding appropriate treatment. Question 23. A 3-year-old child presents with a sudden onset of wheezing, cough, and increased work of breathing after playing with small toys. They are conscious but agitated. What is the most likely cause? A. Asthma exacerbation. B. Croup. C. Foreign body airway obstruction, FBAO. D. Bronchiolitis. Answer, C. Foreign body airway obstruction, FBAO. This question presents a classic scenario of an acute airway emergency in a young child. The concept being tested is the recognition of foreign body airway obstruction. The keywords sudden onset, wheezing, cough, increased work of breathing, and after playing with small toys strongly suggest a foreign body is lodged in the airway. Unlike asthma, which often has a trigger and history, or croup with its distinctive barking cough, FBAO is an acute, mechanical obstruction. For example, a child who suddenly starts coughing and choking after putting a small toy in their mouth should be immediately assessed for a foreign body. Always consider FBAO in a young child with acute respiratory distress, especially if they were recently playing or eating. Question 24. What is the appropriate management for a pediatric patient in pulseless electrical activity, PEA? A. Immediate synchronized cardioversion. B. Defibrillation at 2J/kg. C. High-quality CPR and administration of epinephrine. D. Administration of adenosine. Answer, C. High-quality CPR and administration of epinephrine. This question focuses on the correct management of a specific non-shockable cardiac arrest rhythm. The concept being tested is the PALS algorithm for pulseless electrical activity, PEA. The keyword pulseless electrical activity, PEA, signifies that there is organized electrical activity on the ECG, but no palpable pulse. Since there is no effective cardiac output, PEA is treated as a non-shockable rhythm. The cornerstone of PEA management is continuous high-quality CPR and prompt administration of epinephrine, along with a search for and treatment of reversible causes, H's and T's. For instance, if the monitor shows a normal-looking rhythm but the child has no pulse, you would continue compressions, give epinephrine, and quickly check for causes like hypovolemia or tension pneumothorax. Remember, PEA means the heart has electrical activity but is not effectively pumping blood, so medications and mechanical support are key. Question 25. What is the recommended method for performing chest compressions on an infant during true rescuer CPR? A. One-hand technique. B. Heel of one-hand technique. C. Two-thumb encircling hands technique. D. Two-finger technique. Answer, C. Two-thumb encircling hands technique. This question specifically asks about optimal chest compression technique for infants when two rescuers are present. The concept being tested is the proper execution of high-quality CPR in a team setting. The keywords two rescuer CPR and infant are critical. The two-thumb encircling hands technique is the preferred method for two rescuer CPR on an infant because it provides better compression depth and less rescuer fatigue compared to the two-finger technique. In this method, the rescuer's hands encircle the infant's chest, and the thumbs press on the lower half of the sternum. For example, with one rescuer providing ventilations and the other performing compressions, the thumbs encircling method ensures efficient compressions. Remember, teamwork and correct technique are vital for effective infant CPR. Question 26. A 1-year-old child presents with a heart rate of 240 bpm, narrow QRS complex, and signs of poor perfusion, lethargy, pale, cool extremities. Which treatment is indicated first? A. Synchronized cardioversion at 0.5-1J/kg. B. For adenosine 0.1 mg/kg. C. Immediate defibrillation. D. For fluids 20 milliliters per kilogram. Answer. A. Synchronized cardioversion at 0.5-1J/kg. This question describes a child with symptomatic supraventricular tachycardia, SVT, requiring immediate intervention. The concept being tested is the management of unstable tachycardia in a pediatric patient. The keywords heart rate of 240 bpm, narrow QRS complex, and signs of poor perfusion, lethargy, pale, cool extremities indicate unstable SVT. When a child has SVT with signs of instability, synchronized cardioversion is the immediate treatment of choice, starting at 0.5-1J/kg. While 4-adenosine is used for stable SVT, the child's poor perfusion necessitates immediate electrical therapy. For example, if adenosine fails or the child is too unstable to wait for 4-access, cardioversion is the quickest way to restore a normal rhythm. Remember, unstable tachycardia always warrants immediate synchronized cardioversion. Question 27. What is the appropriate initial management for a child presenting with respiratory distress due to suspected bronchiolitis, who is alert, but has a respiratory rate of 60 bpm and mild retractions? A. Immediate intubation. B. Administer albuterol nebulizer. C. Provide oxygen, suction nasal secretions, and monitor closely. D. Administer systemic corticosteroids. Answer. C. Provide oxygen, suction nasal secretions, and monitor closely. This question presents a common pediatric respiratory illness scenario, bronchiolitis. The concept being tested is the appropriate initial management of respiratory distress in suspected bronchiolitis. The keywords bronchiolitis, alert, respiratory rate of 60 bpm, and mild retractions describe a child in mild to moderate respiratory distress. Management for bronchiolitis is primarily supportive, focusing on maintaining oxygenation and clearing the airway. This includes providing supplemental oxygen to keep oxygen saturation above 90 to 92% and suctioning nasal secretions to improve airflow. For example, a baby with lots of snot from bronchiolitis will breathe much easier if their nose is cleared with a bulb syringe before feeding. Remember, medications like albuterol or steroids are generally not recommended for routine bronchiolitis. Question 28. What is the most critical element to ensure during chest compressions in pediatric CPR? A. Delivering ventilations every 2 seconds. B. Pausing compressions for rhythm analysis every 30 seconds. C. Achieving adequate depth and full chest recoil. D. Maintaining a compression rate of exactly 100 per minute. Answer. C. Achieving adequate depth and full chest recoil. This question focuses on the quality aspects of chest compressions during CPR. The concept being tested is the emphasis on high-quality chest compressions. The keyword most critical element points to the fundamental actions that maximize the effectiveness of compressions. While rate is important, achieving adequate compression depth, at least 1/3 the AP diameter of the chest, and allowing for full chest recoil between compressions are paramount to ensuring sufficient blood flow to the heart and brain. Incomplete recoil reduces venous return and cardiac output. For example, if you push too shallowly or lean on the chest, the heart won't fill properly between compressions, making them less effective. Always ensure you are pushing deep enough and completely letting up between each compression. Question 29. A 2-year-old child weighs 12 kilograms. During cardiac arrest, what is the correct dose of amiodarone for the first bolus? A. 3 mg per kilogram 4/IO. B. 5 mg per kilogram 4/IO. C. 10 mg per kilogram 4/IO. D. 15 mg per kilogram 4/IO. Answer: B. 5 mg per kilogram 4/IO. This question tests your knowledge of antiarrhythmic medication dosing in pediatric cardiac arrest. The concept being tested is the correct first dose of amiodarone. The keywords amiodarone, cardiac arrest, and first bolus indicate that the child is in a shockable rhythm that has not responded to defibrillation. For a pediatric patient in cardiac arrest with a shockable rhythm, VF/private, that persists after initial defibrillation and epinephrine, the first dose of amiodarone is 5 mg per kilogram, administered intravenously, or intraosseously, IO. For example, a 12 kg child would receive 60 mg of amiodarone. Remember this specific dose as part of the cardiac arrest algorithm when defibrillation and epinephrine are insufficient. Question 30. You are assessing a 6-month-old infant using the Pediatric Assessment Triangle, PAT. You note the infant is extremely irritable, crying inconsolably, has increased work of breathing with nasal flaring, and pale, mottled skin. This presentation suggests A. Compensated respiratory distress. B. Respiratory failure and compensated shock. C. Decompensated shock with no respiratory compromise. D. Good physiological status. Answer: B. Respiratory failure and compensated shock. This question requires you to interpret multiple findings from the Pediatric Assessment Triangle, PAT, to identify a severe underlying condition. The concept being tested is the ability to integrate PAT components, appearance, work of breathing, circulation, to determine physiological status. Extremely irritable, crying inconsolably, appearance, suggests CNS compromise due to hypoxia or poor perfusion. Increased work of breathing with nasal flaring indicates significant respiratory distress that could be progressing to failure. Pale, mottled skin, circulation, points to poor perfusion, likely compensated shock given the irritability. For instance, a baby presenting this way needs immediate intervention for both breathing and circulation. Recognize that multiple abnormal PAT signs usually indicate a very sick child with multi-system involvement. Question 31. After successful resuscitation and return of spontaneous circulation, RO-SCI, in a pediatric patient, what is the primary goal of post-cardiac arrest care related to oxygenation and ventilation? A. Aggressive hyperventilation to blow off CO2. B. Titrate oxygen to achieve SpO2 of 98 to 100%. C. Titrate oxygen to achieve an SpO2 of 94 to 99%. D. Maintain hypocarbia, low CO2, to reduce cerebral edema. Answer: C. Titrate oxygen to achieve an SpO2 of 94 to 99%. This question addresses a crucial aspect of post-resuscitation management in children. The concept being tested is optimal oxygenation and ventilation strategies after return of spontaneous circulation, RO-SCI. The keyword primary goal and post-cardiac arrest care guide you to the specific recommendations for maintaining stability. After ROSC, it's important to titrate oxygen to maintain an oxygen saturation, SpO2, of 94 to 99%. Both hypoxemia, low oxygen, and hyperoxemia, too much oxygen, can be harmful. For example, giving 100% oxygen unnecessarily can cause oxidative stress. Avoid aggressive hyperventilation, as it can decrease cerebral blood flow and worsen neurological outcomes. Remember, the goal is to provide just enough oxygen to ensure adequate tissue perfusion without overoxygenating. Question 32. What is the initial drug of choice for a pediatric patient with symptomatic bradycardia, pulse less than 60 bpm with poor perfusion, that persists despite adequate ventilation and oxygenation? A. Atropine. B. Amiodarone. C. Epinephrine. D. Lidocaine. Answer: C. Epinephrine. This question addresses the pharmacological management of symptomatic bradycardia in children. The concept being tested is the first-line medication for slow heart rates causing clinical compromise. The keywords symptomatic bradycardia and persists despite adequate ventilation and oxygenation indicate a serious, persistent problem requiring medication. For a child with symptomatic bradycardia, heart rate less than 60 bpm with signs of poor perfusion, after ensuring adequate ventilation and oxygenation, the initial drug of choice is epinephrine. Epinephrine works to increase heart rate and myocardial contractility. For example, if a child's heart rate remains very slow and they are lethargic even after receiving breaths and oxygen, epinephrine would be the next step. Remember, oxygenation and ventilation are always the very first steps for bradycardia, but if ineffective, epinephrine is next. Question 33. Which of the following is considered a reliable indicator of effective chest compressions during pediatric CPR? A. Palpable carotid pulse. B. Increased end-tidal CO2, EtCO2. C. Visible chest rise with each compression. D. Decreased heart rate. Answer: B. Increased end-tidal CO2, EtCO2. This question focuses on monitoring the quality of CPR. The concept being tested is how to objectively assess the effectiveness of chest compressions. The keyword reliable indicator points to a quantifiable measure of blood flow. During CPR, an increase in end-tidal CO2, EtCO2, is a reliable indicator of effective chest compressions because it reflects the amount of CO2 being delivered to the lungs by the circulating blood. A sudden significant rise in EtCO2 also suggests return of spontaneous circulation, ROSC. For example, if you see the EtCO2 reading on the monitor increase from 10 mm of mercury to 25 mm of mercury, it suggests that your compressions are improving blood flow. Keep in mind that consistent EtCO2 monitoring is a powerful tool to guide CPR quality. Question 34. What is the recommended management for a child with suspected moderate to severe dehydration due to gastroenteritis who is conscious but tolerating oral fluids poorly? A. Oral rehydration solution, ORS, via nasogastric tube. B. For fluids at maintenance rate. C. For fluid bolus 20 ml per kilogram of isotonic crystalloid. D. Administer antiemetics and try oral fluids again. Answer: C. For fluid bolus 20 ml per kilogram of isotonic crystalloid. This question addresses the management of pediatric dehydration, a common scenario. The concept being tested is fluid resuscitation for moderate to severe dehydration when oral intake is insufficient. The keywords moderate to severe dehydration, gastroenteritis, and tolerating oral fluids poorly indicate a need for more aggressive fluid management. For a child with moderate to severe dehydration who cannot take fluids orally, and 4 fluid bolus of 20 ml per kilogram of isotonic crystalloid, e.g., normal saline, is the most appropriate initial intervention to rapidly restore circulating volume. For example, if a child is lethargic and has synchronized due to dehydration and can't keep down ORS, and 4 fluid bolus is necessary. Remember, rapid rehydration is key to preventing shock in dehydrated children. Question 35. During a resuscitation attempt, a child in cardiac arrest suddenly develops significant abdominal distension. What is the most likely cause and appropriate intervention? A. Gastric rupture, administer 4 fluids. B. Air trapping in the lungs, provide bronchodilators. C. Gastric insufflation from ventilation, insert an orogastric tube. D. Internal bleeding, prepare for immediate surgery. Answer: C. Gastric insufflation from ventilation, insert an orogastric tube. This question addresses a common complication during pediatric resuscitation. The concept being tested is the recognition and management of gastric distension. The keywords cardiac arrest and significant abdominal distension point to gastric insufflation. During CPR, especially with bag mask ventilation, air can inadvertently be forced into the stomach, causing distension. This distension can impair diaphragmatic movement, reducing lung expansion and increasing the risk of aspiration. The appropriate intervention is to insert an orogastric (OG) tube to decompress the stomach. For example, if you notice the child's belly getting bigger and their chest rise decreasing, inserting an OG tube can quickly relieve the pressure. Remember, gastric distension complicates ventilation and should be addressed promptly. Question 36. What is the minimum recommended frequency for reassessment of a pediatric patient in unstable conditions, such as shock or respiratory failure? A. Every 15 minutes. B. Every 10 minutes. C. Every 5 minutes. D. Every 1 minute or continuous. Answer: D. Every 1 minute or continuous. This question emphasizes the importance of frequent monitoring in critically ill children. The concept being tested is the appropriate frequency of reassessment for unstable pediatric patients. The keywords minimum recommended frequency and unstable conditions, such as shock or respiratory failure, highlight the need for continuous vigilance. For a child in an unstable condition, reassessment should be continuous, or at a minimum, every 1 minute. Their condition can change rapidly, and frequent monitoring allows for timely adjustments to treatment. For example, if a child is in shock, you would be continuously monitoring their heart rate, respiratory rate, blood pressure, and perfusion, reacting instantly to any changes. Always remember that a rapidly changing condition demands constant vigilance and immediate response. Question 37. Which of the following is a common cause of obstructive shock in a pediatric patient? A. Severe dehydration. B. Sepsis. C. Tension pneumothorax. D. Anaphylaxis. Answer: C. Tension pneumothorax. This question requires you to identify a specific cause of obstructive shock in children. The concept being tested is the understanding of different types of shock and their etiologies. The keyword obstructive shock refers to a condition where blood flow to or from the heart is physically impeded. A tension pneumothorax is a classic example of obstructive shock where air accumulates in the pleural space, collapsing the lung and shifting the mediastinum, thereby compressing the great vessels and heart and severely impairing venous return. For example, a child with chest trauma who develops sudden respiratory distress, hypotension, and tracheal deviation could have a tension pneumothorax causing obstructive shock. Remember, obstructive shock is a mechanical problem requiring a mechanical solution. Question 38. A 7-year-old child in cardiac arrest is receiving CPR. After 2 minutes, the rhythm is reanalyzed as asystole. What is the most appropriate next step? A. Deliver an immediate defibrillation. B. Continue CPR and administer epinephrine. C. Administer amiodarone. D. Stop CPR and declare death. Answer: B. Continue CPR and administer epinephrine. This question tests the management of a non-shockable rhythm during pediatric cardiac arrest. The concept being tested is the specific steps in the PALS cardiac arrest algorithm for asystole. The keywords cardiac arrest, asystole, and next step are critical. Asystole is a non-shockable rhythm, meaning defibrillation is not effective. Therefore, the most appropriate next step is to continue high-quality chest compressions and ventilations, and administer epinephrine as soon as possible. For instance, if the monitor shows a flat line, you would ensure continuous compressions are being performed and prepare to give the first dose of epinephrine. Always remember that for asystole, focus on high-quality CPR and epinephrine. Question 39. What is the primary reason for providing bag mask ventilations before initiating chest compressions in most pediatric cardiac arrest situations where a single rescuer is present? A. To prevent gastric distension. B. To ensure oxygenation, as respiratory failure is the most common cause of cardiac arrest in children. C. To check for a pulse more accurately. D. To activate the emergency response system. Answer: B. To ensure oxygenation, as respiratory failure is the most common cause of cardiac arrest in children. This question delves into the rationale behind initial BLS steps for pediatric patients. The concept being tested is the fundamental difference in cardiac arrest etiology and initial management between children and adults. The keyword primary reason emphasizes the underlying physiological basis. In children, cardiac arrest is most commonly secondary to progressive respiratory failure or shock, meaning a lack of oxygen is often the precipitating event. Therefore, providing initial ventilations helps to address the primary problem and potentially prevent progression to cardiac arrest, or improve outcomes if it's already occurred. For example, if a child collapses due to severe asthma, delivering rescue breaths first provides crucial oxygen that might restart their heart. Remember, for most pediatric collapses, lungs first is a good principle. Question 40. A child experiencing a severe asthma exacerbation is unresponsive to albuterol and ipratropium. They are now becoming fatigued with decreasing wheezing and a rising CO2. What is the most appropriate next step? A. Administer another dose of albuterol. B. Continue to monitor and reassess. C. Prepare for intubation and mechanical ventilation. D. Administer magnesium sulfate. Answer: C. Prepare for intubation and mechanical ventilation. This question describes a child whose severe asthma exacerbation is progressing to respiratory failure. The concept being tested is the recognition of impending respiratory failure in asthma and the need for advanced airway management. The keywords unresponsive to albuterol and ipratropium, becoming fatigued, decreasing wheezing, and rising CO2 are all ominous signs. Decreasing wheezing in a severe asthmatic is a critical sign of worsening air trapping and impending respiratory arrest, as they can no longer move enough air to even wheeze. This indicates the child is tiring out and needs advanced airway support. For instance, if a child with asthma goes from loud wheezing to barely audible breath sounds and looks exhausted, they are in immediate danger of respiratory arrest. Recognize that a silent chest in severe asthma is a medical emergency. Question 41. What is the most appropriate initial management for an infant with a heart rate of 70 bpm, who is lethargic, pale, and has a respiratory rate of 8 breaths/min? A. Administer atropine. B. Start chest compressions. C. Provide high-quality ventilation and oxygenation. D. Prepare for synchronized cardioversion. Answer: C. Provide high-quality ventilation and oxygenation. This question tests the initial management of symptomatic bradycardia in an infant. The concept being tested is the crucial first steps in the bradycardia algorithm. The keywords heart rate of 70 bpm, lethargic, pale, and respiratory rate of 8 breaths/min indicate an infant with symptomatic bradycardia. In infants, a heart rate less than 60 bpm with signs of poor perfusion warrants immediate chest compressions. However, for a rate above 60 bpm but still symptomatic, the first and most critical step is to provide high-quality ventilation and oxygenation, as hypoxia is the most common cause of bradycardia in infants. For example, if a baby is breathing slowly and looks dusky with a slow heart rate, giving effective breaths with a bag mask device and oxygen is the priority. Only if bradycardia persists below 60 bpm despite good ventilation and oxygenation would compressions be started. Question 42. In a pediatric patient, what is the most common initial presentation of septic shock? A. Cold shock with bradycardia. B. Warm shock with low blood pressure. C. Warm shock with high blood pressure. D. Cold shock with tachycardia. Answer: D. Cold shock with tachycardia. This question addresses a common and critical form of shock in children, septic shock. The concept being tested is the typical clinical presentation of septic shock in pediatric patients. The keyword most common initial presentation is key. While adults often present with warm shock, vasodilation, warm extremities, children, especially infants, commonly present with cold shock, characterized by vasoconstriction, cool and mottled extremities, prolonged capillary refill, and a compensatory tachycardia to maintain cardiac output. For example, an infant with an infection who becomes lethargic, has a very fast heart rate, and cool, clammy skin is likely in cold septic shock. Recognizing this presentation allows for prompt fluid resuscitation and antibiotic administration. Question 43. After obtaining return of spontaneous circulation, ROSCI, a 5-year-old child remains comatose. What intervention is recommended to manage fever in this patient? A. Allow a mild fever, up to 39 degrees C, to facilitate recovery. B. Actively cool the child to achieve therapeutic hypothermia, 32-34 degrees C. C. Actively prevent and treat fever, aiming for normothermia, 36-37, 5 degrees C. D. Administer broad-spectrum antibiotics to prevent infection-related fever. Answer: C. Actively prevent and treat fever, aiming for normothermia, 36-37, 5 degrees C. This question focuses on temperature management in the critical post-cardiac arrest period. The concept being tested is the current PALS recommendation for fever control after ROSC in a comatose child. The keywords ROSC, comatose, and manage fever direct you to the guidelines for post-resuscitation care. While therapeutic hypothermia used to be widely recommended, current PALS guidelines recommend actively preventing and treating fever, aiming for normothermia, 36-37, 5 degrees C, in comatose children after cardiac arrest. Hyperthermia, fever, is associated with worse neurological outcomes. For example, if a child's temperature starts to rise after ROSC, you would use antipyretics and cooling measures to keep them in the normal range. Remember, avoiding fever is critical for neuroprotection after cardiac arrest. Question 44. What is the recommended method for foreign body airway obstruction, FBAO, in a conscious infant who is unable to cough effectively? A. Abdominal thrusts. B. Chest thrusts. C. A combination of 5 back blows and 5 chest thrusts. D. Finger sweeps. Answer, C. A combination of 5 back blows and 5 chest thrusts. This question addresses the specific technique for managing a choking infant. The concept being tested is the appropriate intervention for a conscious infant with a severe foreign body airway obstruction. The keywords conscious infant and unable to cough effectively are crucial for identifying the correct, immediate action. For an infant, the recommended technique is a combination of 5 back blows followed by 5 chest thrusts, repeated until the obstruction is relieved or the infant becomes unconscious. Abdominal thrusts are not recommended for infants due to the risk of injury. For example, if a baby is gagging and turning blue after putting a small object in their mouth, you would immediately perform this sequence of back blows and chest thrusts. Remember to support the infant's head and neck properly during these maneuvers. Question 45. A 10-year-old child is in ventricular fibrillation, VF. After the first defibrillation and 2 minutes of CPR, VF persists. What is the next recommended energy dose for defibrillation? A. 2J/kg. B. 4J/kg. C. 6J/kg. D. 10J/kg. Answer, B. 4J/kg. This question tests your knowledge of escalating defibrillation energy doses in pediatric cardiac arrest. The concept being tested is the appropriate energy level for subsequent shocks after initial unsuccessful defibrillation. The keywords ventricular fibrillation, VF, persists after the first defibrillation, and next recommended energy dose highlight the need for a higher shock. If VF or pulseless VT persists after the first defibrillation at 2J/kg, subsequent defibrillation attempts should be at 4J/kg. You can continue to increase the dose up to 10J/kg or the adult maximum. For example, if a 30 kg child received a first shock of 60 J and VF continued, the next shock would be 120 J. Always remember to escalate the energy dose for persistent shockable rhythms. Question 46. What type of shock is characterized by maldistribution of blood flow and peripheral vasodilation, often seen with sepsis or anaphylaxis? A. Hypovolemic shock. B. Cardiogenic shock. C. Obstructive shock. D. Distributive shock. Answer, D. Distributive shock. This question asks you to identify a specific category of shock based on its underlying physiological mechanism. The concept being tested is the classification of shock types. The keywords maldistribution of blood flow and peripheral vasodilation are hallmarks of distributive shock. In this type of shock, severe vasodilation, widening of blood vessels, leads to relative hypovolemia and an inability to maintain adequate blood pressure and tissue perfusion, even with a normal blood volume. Sepsis and anaphylaxis are common causes. For example, a child with a severe bacterial infection whose blood vessels are excessively widened, leading to low blood pressure, is experiencing distributive shock. Understanding the mechanism helps guide treatment, often involving fluids and vasopressors. Question 47. A 3-year-old child presents with a sudden, complete loss of muscle tone, unresponsiveness, and gasping respirations. A lone rescuer is present. After confirming no pulse, What should be the rescuer's first action? A. Activate the emergency response system. B. Perform 5 cycles of CPR, approximately 2 minutes. C. Deliver 2 rescue breaths. D. Search for and treat reversible causes. Answer: B. Perform 5 cycles of CPR, approximately 2 minutes. This question addresses the sequence of actions for a lone rescuer discovering a child in cardiac arrest. The concept being tested is the CAB approach and the importance of early CPR. The keywords lone rescuer, sudden, complete loss of muscle tone, unresponsiveness, and gasping respirations, and confirming no pulse indicate an immediate need for CPR. For a lone rescuer, after confirming cardiac arrest, the priority is to immediately begin chest compressions and ventilations, CPR, for about 2 minutes, approximately 5 cycles, before activating the emergency response system. This ensures the child receives vital oxygen and blood flow as quickly as possible. For instance, if you find a collapsed child, your hands should go to their chest for compressions right away, not to your phone. Remember, early high-quality CPR is paramount for pediatric survival. Question 48. What is the maximum recommended number of attempts for intraosseous (IO) access in a single bone? A. 1 attempt. B. 2 attempts. C. 3 attempts. D. No more than 4 attempts. Answer: B. 2 attempts. This question addresses an important procedural safety guideline for obtaining vascular access in emergencies. The concept being tested is safe practice regarding intraosseous (IO) access. The keyword maximum recommended number of attempts highlights a critical limit. If the initial attempt at IO access in a single bone is unsuccessful, a second attempt can be made in the same bone, preferably with a new needle or at a slightly different site. However, if the second attempt also fails, a different IO site or an alternative vascular access method, like central venous access, should be pursued to prevent excessive damage to the bone. For example, if your first IO attempt in the tibia fails, you can try once more, but then you'd move to the femur or humerus if that also fails. Remember, limiting attempts helps prevent complications like osteomyelitis or compartment syndrome. Question 49. A child has received appropriate fluid boluses for shock, but remains hypotensive and has poor perfusion. Which medication might be indicated next? A. Atropine. B. Epinephrine infusion, vasopressor. C. Adenosine. D. Sodium bicarbonate. Answer: B. Epinephrine infusion, vasopressor. This question addresses the next step in managing refractory shock in a pediatric patient. The concept being tested is the use of vasoactive medications when fluid resuscitation alone is insufficient. The keywords appropriate fluid boluses, remains hypotensive, and poor perfusion indicate fluid refractory shock. When a child in shock does not respond adequately to fluid resuscitation, vasopressor support, such as an epinephrine infusion, is indicated to improve blood pressure and organ perfusion. For example, if a child in septic shock is still hypotensive after receiving multiple fluid boluses, starting an epinephrine drip would help constrict blood vessels and support heart function. Remember, vasopressors are used when the pipes are too wide or the pump is too weak, and fluids alone aren't enough. Question 50. What is the typical appearance of the airway for a child with epiglottitis compared to croup on an X-ray? A. Epiglottitis shows a steeple sign, croup shows a thumb sign. B. Both show a steeple sign. C. Epiglottitis shows a thumb sign, croup shows a steeple sign. D. Neither shows characteristic X-ray findings. Answer, C. Epiglottitis shows a thumb sign, croup shows a steeple sign. This question tests your ability to distinguish between two critical pediatric airway conditions based on characteristic radiological findings. The concept being tested is the differential diagnosis of upper airway obstruction. The keywords epiglottitis and croup are crucial. On a lateral neck X-ray, epiglottitis, which involves swelling of the epiglottis, typically shows a thickened, rounded epiglottis resembling a thumb sign. Croup, which involves subglottic swelling, classically presents with subglottic narrowing resembling a steeple sign on an anterior-posterior (AP) neck X-ray. For example, if a child has a high fever, dysphagia, and drooling, an X-ray might show the thumb sign, prompting immediate airway management precautions. Remember, these distinct X-ray findings can help differentiate these serious conditions, although clinical presentation often guides initial management.